Hello, my name is Marco Niero, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass, and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
NF1 associated glioma in children. It's about the optic pathway glioma and beyond. My name is Amedeo Azizi. I'm head of the Pediatric Neurofibromatosis program at the Medical University of Vienna. These are my disclosures. First of all, I wanted to quickly go over the revised diagnostic criteria for NF1. It's about 6 or more Caffiollet macules. It's about freckling, 2 or more neurofibromas of any type or plexiform neurofibroma, optic pathway glioma, 2 or more iris lesion nodules, or this is new, 2 or more choroidal abnormalities, a distinctive osseous lesion, a heterozygous pathogenic NF1 variant. This is also come new to the diagnostic criteria, or you have a child of a parent who meets diagnostic criteria and who itself fulfills at least one of those criteria listed in A. But what we are going to address today is the diagnostic criteria about optic pathway glioma, but beyond that, also about glioma that occur outside of the optic pathway. And as I'm a pediatric neuro-oncologist, I will mainly focus on the glioma in children. Looking at the overall cancer risk in patients with neurofibromatosis type 1, you can see that the risk for brain and spinal cord tumors is, the relative risk is 46.5 times elevated. For optic pathway glioma, 920 relative risk, other astrocytoma and other glioma around 30. Now I'll come to optic pathway glioma. First to the epidemiology. About 15% of children with NF1 show optic pathway glioma. If you perform MRI screening, which is not routinely performed in every center, you can see, and these are our own data, that about a quarter of those patients with NF1 actually have an optic pathway glioma during childhood. Usually, these tumors present during the first 2 decades of life and mostly before the age of 8 years. And this is also true for symptomatic patients and symptomatic optic pathway glioma, as you can see on this graph here, that here is the age of 10, and almost all those tumors that occur before that age. But of course, these tumors might occur at any age, also in adulthood, but this is quite rare, and they rarely get symptomatic later on in life. Coming to the biology of the tumors, they are rarely biopsied due to a possible risk of function loss due to the biopsy of the optic pathway. But if histology is gained, this histology mostly shows pilocytic astrocytoma, WHO grade 1. There is no clear correlation to the germline NF1 mutation that was found in a recent publication, but some other groups suggest otherwise. Mainly a Chinese group in 2018 found quite some interesting correlations. In that recent publication by Mike Fisher and colleagues, there was always a second-hit somatic NF1 alteration as to be expected in neurofibromatosis type 1, and rarely other changes like FGFR receptor alterations. These apparently seem to lead to a more severe course of the disease. In the meantime, in the last decade, there were murine models that were developed for optic pathway glioma in NF1. Of course, it's very hard to translate those findings into humans, and the testing of function, especially vision, is hardly possible in mice. But you have the chance to test diverse anti-neoplastic agents, like in this publication, for example, by the group of David Gutman. Talking about the optic pathway, we first have to look at the anatomy of the optic pathway. You here have the eyeball, then the optic nerves coming to the chiasm, where there is a crossing of the nasal fibers of the retina. They then go to the optic tract, to the lateral geniculate nucleus, and then from there on through the optic radiation to the occipital cortex. And of course, optic pathway glioma can develop on any part of this optic pathway. This was a study we performed, a pan-European study we performed, recently published. We could see that around 42% of tumors occurred in the optic nerves, around 20% in the chiasm, and around 40% beyond the chiasm, meaning in the tracts and the radiation. Of course, you could go into more detail looking at left and right nerve separately about involvement of both optic nerves or the chiasm, and you could see the different frequencies. Here, this is depicted here in more detail, and I won't go further on that now. So this is an image of a patient with pure optic nerve glioma on both eyes. You see the tortuosity. You see that there is a swelling of the optic nerve sheath. This is a patient where the chiasm is involved, as you can see here or here. And this is a patient where actually the whole optical system is involved, meaning this is a Dodge 1 to Dodge 4, where the optic nerves are involved, the chiasm is involved, and as you can see clearly here on the FLAIR images, the optic tracts and the optic radiation to the back is involved. This is a short video. On this same patient, you see the enlargement of the nerves, of the chiasm, and here you can see the optic tracts, the hypothalamus, and the optic radiation that is involved. About 40 to 50% of optic pathway glioma patients develop visual symptoms. That means that more than half do not. And how to measure vision? This is very important because we need age-appropriate testing methods. Here on the right, you can see teleacuity cards, which are possible to test and to perform already in very young children, even in infants. LEA card is for toddlers, and then there is HOTV for patients that are already able to discern letters. The visual testing in children is very, very depending on the cooperation of the child. So beware, if a child is hungry, tired, grumpy, you will get worse results, meaning that if there is a lack of cooperation, you will have to repeat the visual testing soon to make sure that a possible deterioration is real. But it might well be that you will not be able in young children to get reliable results. What is very important to notify is that actually normal vision is a developing process. it means it improves with age, such as there is growth of body length and of weight, for example. We can also see here percentiles. This is also taken from the publication I mentioned earlier that we performed. So where you can see this is the normal vision. And as you can see, this might differ by testing method. And on that chart, we depicted the visual acuity of the right eye and the left eye over time. So what you can see here is that the visual maturation process takes on over years and should reach normal vision by the age of 3 to 5 years. And what is important to discuss here is that a stagnation of visual acuity can actually be a sign of deterioration because maturation should be ongoing. Now there are objective measures for the optic nerve like OCT. OCT means optic coherence tomography. This is a near-infrared laser that is going over the surface of the retina and going below the surface. And at a high resolution, there will be a cross-sectional image of the retina and the optic nerve that can be done. And you can specifically measure the thickness of the ganglion cell layer and the nerve fiber layer. A decrease in RNFL, which is the nerve fiber layer, precedes visual loss. This was published by Rob Avery in 2015. But of course, it's very difficult to do OCT in young children. You might need anesthesia for handheld devices, which are expensive and are currently hardly available. Normally, using the fixed OCT machines, it is possible to perform OCT above the age of 4. Sometimes, if the child is very cooperative, might be a bit below that, but it might be hard in those patients who are at the highest need for getting these measurements done. And there is now an objective parameter for progression. So, but the future will tell how this will come into play into routine daily practice. We also analyzed the signs and symptoms that patients present with when they come with an optic pathway glioma. So squint or strabism was present in about a quarter, like abnormal visual behavior. I'll come to that later on. Proptosis, meaning exophthalmos, nystagmus in about 2%, papilledema, and others including endocrine symptoms, signs of raised intracranial pressure. And of course, we were looking at optic atrophy, and around 40% of patients did already show either unilateral or bilateral optic atrophy. So what are the clinical signs and symptoms in those patients that do get symptomatic? Because remember, about 50% of cases and even more stay asymptomatic. Well, it's proptosis, exophthalmos, as mentioned before, it's squint, it's stumbling over obstacles. This is how the parents come into the daily practice. It's saying, okay, while my child runs into obstacles, stumbles over them, he does not recognize small things like distant birds. And this is what you should pick up when seeing such a patient. Eye trembling, the nystagmus is a very, very late sign when visual acuity is really poor. And beware, children can compensate a lot. And so I have seen children that were almost blind, but the parents didn't believe me when I was telling them that there was very poor vision only present because the child was not that affected in daily life. This is why we have to check for it. Prospective data on the natural history and risk factors for visual progression are scarce. So we know that only 20% of all patients with optic pathway glioma actually are treated, around 50% of symptomatic patients, which is, if you take all NF1 patients, around 3 to 5% of all NF1 patients. The visual risk is unpredictable, so far at least. Data on natural history and visual risk factors in children scarce, as mentioned before, and factors correlated with poor visual outcome include age, meaning young age under the age of 2 or above the age of 5, tumor extension to the posterior optic tracts, meaning beyond the optic chiasm, optic disc pallor, which is a late sign, so the optic nerve has already partially died, and girls apparently have a higher risk for vision loss and the need for treatment due to visual loss. According to Fisher et al., the visual outcomes after treatment do not differ from boys. This was actually not replicated in other groups. Either they could not show the high risk for girls, or there was a recent publication that actually said that even though they receive treatment, they have a poorer visual outcome than boys. So, factors at diagnosis that were associated with an adverse visual outcome were presence of multiple visual signs and symptoms, abnormal visual behavior, like the symptoms I've told you before, new onset of visual symptoms, optic atrophy, which is a late sign, squint, posterior visual pathway tumor involvement, and bilateral pathway tumor involvement showed borderline significance in our pan-European study. So, what to do once an optic pathway glioma is diagnosed? After diagnosis of an optic pathway glioma, there should be follow-up by MRI. Every 3 months in the first year after diagnosis, then every 6 months until the age of about 8 years. Ophthalmologic examination by an experienced pediatric ophthalmologist or neuro-ophthalmologist should be done every 3 months until the age of about 8 years, when the high-risk age seems to come to an end. Only 20% of all patients with optic pathway glioma are treated, as I told you before. So if you look at the age when they get treated, you can see this is the age at diagnosis. It is shifted a bit towards a higher age, and the interval from OPG diagnosis to the start of treatment is so that most children get treated quite soon after diagnosis and only rarely thereafter. So, when to treat a child? According to visual progression or tumor progression. For proptosis, for exophthalmos, that means, then what would you do? You would give chemotherapy. The gold standard of chemotherapy is carboplatin and vincristine, and alternatively, vinblastine, as published by the Canadian group. So this is the scheme that is used in Europe for the time being, the SALP low-grade glioma 2004 induction scheme, with a induction done over 7 cycles and then 10 cycles of consolidation therapy, all consisting of carboplatin and vincristine. The Americans have a slightly different scheme with weekly carboplatin, but the end effect is very comparable. The response to this kind of chemotherapy is better than in sporadic low-grade glioma. It leads to effective tumor control, and possible side effects are drop in blood count, hair loss, nausea, neuropathy due to vincristine, abdominal pain, and hearing loss, which is quite rarely seen but is a possible side effect. Often, and up to 30% of patients, allergies to carboplatin might occur that necessitate stopping treatment or changing treatment. Mostly these are mild, like a cold, a cough, a fever, rarely severe with an anaphylactic shock. So who does actually profit from treatment? Visual outcomes are independent of radiological response. So you might have tumors that respond quite well radiologically, but where vision still does not profit. And the visual risk is still unpredictable. This is one of our kids that we've seen. We did MRI screening for that child. We didn't see any optic pathway glioma above the age of 1 year. visual acuity was seen as being normal. Visual acuity was not able to being assessed. At the age of 2, the patient had developed a large chiasmatic tumor. Since there was so rapid progression, we decided to treat the child, although the ophthalmologist said still normal visual behavior, but without a measurable visual acuity. So what happened? The tumor actually completely vanished and went away. But at the last exam of the ophthalmologist, there was 100% vision, 0.1 decimal of 20/20 vision on the right eye, whereas the left eye only had light perception. So we treated a child that others might not have treated because the ophthalmologist said everything's fine, and we could save his vision on the right eye, but still then he lost his vision on his left eye. Looking at the overall cohort of those patients that get treated, you can see that around 32% have improved vision, 40% stable vision, and around 28% see worsening of vision despite therapy. From that study mentioned earlier on that we performed on the European level, we saw that in the observation cohort, visual acuity didn't change much over time, which is, of course, what we would expect in this cohort. Then we had those patients that were very bad with vision or had large tumors, had other reasons to treat at diagnosis. And what we can see here is that many of those patients actually turned worse despite treatment. But what we also could see is that those that were treated after an observation phase had quite some amount of treatment responses, whereas you can see there was a worsening during the observation period. You see that many of those could be salvaged at a later stage. There is a way to present this where the visual acuity, this is logMA, meaning 0.0 is 100% vision of the left and right eye as seen on that chart. And for those that get only observed, you see that they have a pretty good vision over time and keep that. On those that get observed first, you see that they resemble actually the observation group, but then they tend to lose vision on at least one eye. And what you can see here after treatment, quite a few of them come back to the field where we would expect them to have very good vision on both eyes, whereas others still see deterioration. And coming to those that get treatment at the very beginning, you see that the vision was already bad at the very beginning, and only very few could be actually salvaged, whereas the others, at least one eye, turned blind. So what about radiation therapy, which is a therapy option in a sporadic low-grade glioma and be it a second or third line option? It has to be avoided in NF1 patients for low-grade glioma. There is a risk of secondary tumors like high-grade gliomas, malignant peripheral nerve sheath tumors, vascular complications like moyamoya or stroke, neuropsychological sequelae, and endocrine problems that might arise. So radiation therapy is only in case of highly malignant tumors and not optic pathway glioma. So should we do MRI screening for optic pathway glioma in NF1? So far, there are no uniform guidelines, but I'll come to that later on because we are about to draft such guidelines. And the present recommendations were to perform only eye exams. Why? Because only half of patients are symptomatic, only a small part of patients need therapy. Treatment starts mostly in cases of visual deterioration or protrusion of the eye, so you would catch it anyway. Can early treatment prevent visual deterioration? There is no data, so no evidence. The data that I've showed you about our group seems to show that actually it does matter if you catch it early. If you look at the other side, eye exam might be unreliable in young children with neurofibromatosis type 1, and the MRI may play a role, as shown by some groups that could prove that by catching them early, you could improve visual outcome. On the other hand, there are other groups that say that they should show no correlation to having a positive effect of MRI screening. And new sequences may predict visual deterioration. This has been shown, for example, by Peter de Blanc. So what are the future tasks for when looking at screening for OPG in NF1? To define patients at risk. Maybe genetics might help. We are not yet there yet. If fractional anisotropy, as I've mentioned before, of the optic tracts might predict visual decline in the following year, this might be some factor that would be in favor of having MRI screening. And of course, if you could optimize the treatment options and algorithms to prevent visual progression, then of course it might be interesting to do MRI screening. I'll now go through the guidelines that have been drafted by the European Reference Network GenTouris for the genetic tumor risk syndromes at a subgroup of neurofibromatosis type 1. We performed a literature review, had experts come together to give their recommendations, and we had then 3 rounds of Delphi process to reach agreement on those recommendations. They are about to be published, so be aware the following recommendations are preliminary and not yet published. Recommendation 1 is that clinical assessment for OPG should begin immediately after diagnosis. It should be done by trained pediatric ophthalmologists and should include age-appropriate visual assessment, if possible visual fields, pupillary testing, eye movements, and optic disc appearance, meaning optic atrophy. OCT might be helpful in the future. For children until the age of 8 without known optic pathway glioma, the assessment should be done at least yearly. Every 6 months is preferable if feasible. In children above the age of 8 years and without known optic pathway glioma, formal annual visual screening is advised until adulthood. And of course, it should be done as soon as a patient comes in with new visual symptoms. So when to do MRIs for OPG? Well, it should be done if the eye examination is suggestive for an optic pathway glioma. Or, and this is very important, if the eye examinations are inconclusive or unreliable, e.g. Due to age or attention deficit. So if you do then MRI screening, has to be decided by the treating physician and the parents. So patients with asymptomatic optic pathway glioma should be referred to a unit with expertise. And if they have symptomatic optic pathway glioma, they should urgently get referred to decide on whether and how to treat those patients. So beyond the optic pathway, now we're talking about glioma that occur outside of the optic pathway. Here you see an optic, here you see a local glioma, pilocytic astrocytoma of the basal ganglia in the cerebellar hemisphere and of the brain stem. The frequency is about 1 to 3% in children with neurofibromatosis type 1. The standardized incidence ratio compared to non-populations is quite a novel publication by Sirko Peltonen, shows a standardized incidence ratio of about 59. Low-grade glioma represent the vast majority of tumors outside of the optic pathway in children. Pilocytic astrocytoma, if you do biopsy, is present in about 64%. Rarely diffuse glioma or ganglioglioma. This has been recently shown. And more aggressive, I've told that before, behavior was seen in patients that had additional FGFR mutations in their tumors. The clinical signs and symptoms of brain tumors are independent of histology. They are dependent on the tumor site, the age of the child, and meaning therefore the developmental stage. The causes might be direct by infiltration or compression of normal CNS structures, or rather indirect by obstruction of cerebrospinal fluid or increase of intracranial pressure by intracranial mass. If we're talking about intracranial hypertension, we're talking about headaches that are present in up to 70% of vomiting, up to 85% of those patients. But of course, there might be papilledema leading to visual loss, double vision due to abducens palsy, an increase in head circumference in children below the age of 3 is very likely to happen. There might be mass movement with secondary brainstem dysfunction, loss of consciousness, and at a late stage, there might be circulatory dysfunction, respiratory dysfunction, and ultimately death. But very frequent also are focal symptoms, like seizures, motor sensory dysfunction, gait ataxia, for example, for cerebellar tumors, endocrine dysfunction, like precocious puberty that might be seen in NF1, and others, of course. This is the case of tectum glioma that is not that infrequent in children with NF1. You can see here that there is a thickening of the tectal plate that obstructs the aqueduct leading the cerebrospinal fluid to the fourth ventricle, therefore leading to obstructive hydrocephalus. In those patients, you can do third ventriculostomy, meaning neurosurgically putting a hole into the floor of the third ventricle. And what you can see here is what we call on the MRI a floboid sign. You see this dark and hypo-intense signal here shows that there are protons running out of the MRI field, showing that those are flowing through the third ventriculostomy. And what you can see here is that the hydrocephalus is already decreased shortly after the operation. Actually, those patients don't need any further treatment than just having alleviation of the hydrocephalus. Brainstem glioma are not that uncommon in patients with NF1. In about 9% of all CNS tumors, those can be seen. And what is very important, most of them just can be observed in asymptomatic patients. And those tumors must in no circumstance be confounded with malignant midline glioma H3K27M mutated or with loss of H3K27 methylation. So because these have a very poor prognosis and can be found in sporadic cases, meaning in children without NF1, whereas those tumors that we can see here are very low grade and they might even regress spontaneously with age. But of course, if those patients get symptomatic or these lesions start growing, then you need a therapy like the low-grade therapy I've mentioned before, and those only in symptomatic patients. So what is the treatment of choice for non-optic low-grade glioma in children? The decision has to be taken by a multidisciplinary team, an experienced one. Incidental findings often don't need treatment. A watch and wait may be indicated in those. And for symptomatic lesions, there are the same indications for treatment as in sporadic low-grade glioma. Surgery has to be done if safely feasible and may be curative. The gold standard of non-surgical therapy is chemotherapy with carboplatin vincristine, same as the one that I've mentioned before. And radiation therapy has to be avoided due to late toxicity. I've mentioned that before. This is a study of a European cohort of children with low-grade glioma. And what you can see here is that the overall survival is very high. So those patients don't die from their low-grade glioma. And those are the patients that needed non-surgical therapy. But I have to mention that this was actually a study where almost exclusively patients actually receiving therapy were included. So this line here of the event-free survival is not really something that should be taken too seriously. But on the other hand, if you look at those patients that received chemotherapy, you can see that around 60% have a long-term progression-free survival, which is higher than in the group of sporadic low-grade glioma. But high-grade glioma do occur in patients with NF1. They occur more frequently than they would in the normal population. But they are rare in children and more frequent in adults. If you look at this recent publication in Nature Medicine, you can see that the low-grade, which is the blue line, the low-grade glioma is more prevalent in childhood, whereas the high-grade glioma is more prevalent in the adult population. Additionally to the homozygous loss of NF1, you can see TP53 and CDKN2A alterations and ATRX mutations. And once again, those ATRX mutations are more frequent in the adult population and quite rare in the pediatric population. So overall, these tumors are rare in children. But this is one of our patients that presented with seizures. Now he's a 5-year-old boy. He presented at age 3. He had a lesion that was classified as high-grade glioma, not otherwise specified. But what we could show, beside the NF1 mutation that was present homozygosly, we saw a TP53 mutation that apparently conferred that negative clinical course of that child, who is just right now receiving irradiation therapy for this huge, highly malignant mass. And there are those guidelines of the Gentouris also for children with non-optic pathway glioma. So what these guidelines say is that the families and patients should be educated about symptoms and signs of brain tumors. We should take a history and check for these signs and symptoms at every clinical visit. Routine diagnostic imaging for screening is not recommended, although if there is any clinical concern, then of course you should do investigative imaging. And symptomatic non-optic pathway glioma in children should be treated by the same care pathway as sporadic non-OPG in children without NF1. And once again, a multidisciplinary team should decide on those options. And radiation therapy should be avoided in low-grade glioma, but sometimes in high-grade glioma, it might be necessary. So what about PHASI versus glioma? What are PHASI? PHASI are focal areas of signal intensity. Formerly we called them UBOs, unidentified bright objects, or T2 hyperintensities. Even more, in the past, they were called hematoma. They are best seen on FLAIR and T2 imaging, are very frequently present in basal ganglia, cerebellum, brainstem, thalamus, subcortical white matter. They occur with a frequency of 50 to 80%, and they are caused by dysmyelination and fluid accumulation, vacuolation of the myelin sheaths. There are differences in MR spectroscopy and TTI to normal brain, but of course also to glioma. And the natural cause might show an increase in young age, often followed by a decrease in adolescence. In some patients, though, it might further increase. And it was already suggested as a diagnostic criterion for NF1, which was actually not then done in the last guidelines. So there was a correlation with neurocognitive deficits that has been described, and improvement of neurocognitive function correlates to reduction of UBOs with age, but there was no correlation with social or emotional parameters. So how to differentiate PHASI from glioma? You can do MRI spectroscopy. PHASI usually don't take up contrast enhancement, and they are not space occupying, so they show no increased volume. Now we have here 3 examples where you could see T2 hyperintensities. You can see here a brainstem lesion, here lesions in the nuclei of the cerebellum, here a lesion in the cerebellum and brainstem area, and here in the pons. And how could you differentiate them? Actually, here we did a MRI spectroscopy. You see an increased choline peak, meaning that this is a low-grade glioma, whereas those are PHASI. There is volume increase in these lesions, so this is considered to be a low-grade glioma of the pons, not a diffuse pontine glioma H3K27M. Once again, this has to be noted. And same here, you see an increased mass, so meaning that this probably is a low-grade glioma. So what are the future perspectives now? If we talk about future perspectives, we have to go back to the roots. looking at the molecular basis of NF1, so about the RAF pathway that leads to cell activation. If you look at the pathway and it is deactivated, I always compare that to a light bulb and a switch. Then you can switch on that pathway. When a growth factor comes along, there is RAS GDP is turned over to RAS GTP that leads to RAF MEK ERK activation and then cell growth due to transcription factors. And neurofibromin is turning off that switch. So in neurofibromatosis type 1, the switch is active because neurofibromin is missing, and the light bulb is on, and cell growth is going on. So nowadays we have novel drugs like MEK inhibitors that can stop that pathway, that can, although the switch is still turned on, stop cell growth. So what about MEK inhibition in low-grade glioma? There was a publication by Jason Fangozzaro in 2019 showing the use of selumetinib in patients with NF1. 25 patients with NF1 were included. These were pediatric patients. About half of them had optic pathway glioma, and most of them received 2 years of treatment if the tumor was at least stable. About 40% had sustained partial response. 17 of 25 patients were without progression during treatment, and there was a 2-year PFS of 96%, which in relapsed patients is quite a success. And around 64% of patients completed all 26 courses. Here you can see this PFS curve, and you can see here the 24-month to year period. So this is a waterfall plot of the greatest changes to baseline. And there is an ongoing study by the COG, and possibly this should also come to Europe in a cooperation with SAIB Europe, where you compare the standard chemotherapy of carboplatin, vincristine, versus selumetinib in first line, and the outcome is vision as well as radiological progression. For plexiform neurofibroma, selumetinib has been approved in the US in 2020 and in Europe, the European Union and UK by the EMA in 2021. But this seems to be a class-wide effect. Other MEK inhibitors seem to be as effective, and this has been published in multiple case reports and studies, like, for example, with trametinib. What are possible side effects of MEK inhibitors? The most common is rash in about 60 to 70% of children, acneiformic or eczematous. The laboratory values might be elevated, like muscle enzymes like CK. Pyronychia and inflammation of the nails is quite common and might be quite annoying for patients. Loss of appetite, nausea, diarrhea, vomiting have been reported. Something that is quite rare is a possible retinal detachment, which can be diagnosed in OCT and might go away or will go away if you stop treatment. This has been published by Rob Avery in 2016. Heart failure has been described, which is very uncommon, but has been described also in children, and long-term side effects are not really known, as well as possible impact on fertility in 20 years' time. So further novel agents for low-grade glioma and optic pathway glioma, for example, bevacizumab, monoclonal antibody against VEGF, which is effective in progressive low-grade glioma and has been shown to help functional improvement of vision in those patients. What has to be considered is progression after stopping bevacizumab is quite frequent, but still it is effective on retreatment with the drug. Everolimus has been used because there is also activation of the PI3K pathway. This was used in pretreated NF1 low-grade glioma. 68% had an objective response with shrinkage, 12 had stable disease, and was durable response in 66% of patients. And there's a recent publication on the visual outcome of such patients. And we can see here that 19 of 25 eyes were stable, 4 of 25 eyes were getting better, and 2 were getting worse. So, and there was once again discordance of MRI response and vision. There is a French study on bimdestin nilotinib that showed quite some response. The phase 2 data are not yet published. And there was a recent systematic review on ongoing clinical trials in optic pathway gliomas, which includes many, many different agents that are under investigations. Alternative approaches might be drugs aiming at functional improvement, possible treatment aimed at rescuing the retinal ganglion cells, like nerve growth factors. There have been studies on eye drops, but they have not been used widely now. We need more studies on that. Maybe CAMP augmenting agents like phosphodiesterase inhibitors that have been shown to be effective in mice. Can that be a possible option in children? We don't know. Lovastatin has been described in a mouse model, and these have been recently reviewed by David Gutman and his colleague. So when to treat NF1 optic pathway glioma? The question is whether to preserve, or whether to restore vision. Looking at preservation of vision, the pros are more likely to succeed. It prevents further disadvantage for NF patients, but what is against it, it's unclear whom to select for preventive treatment. Standard chemotherapy may be too aggressive, benefit versus side effects, so which drugs to use. And it might be unnecessary, so we might overtreat some of the patients. So restoration of vision, there are clear indications, those with poor vision or visual decline. The cons are therapy may come too late. We might not be able to salvage them anymore. And standard regimens are not very successful in regaining function. Well, in stopping the tumors, but not in regaining function. So it's unclear who may still profit from treatment. So the question for preservation of vision would be, is therapy necessary? Whereas in restoration of vision, it might be, is therapy actually effective? So which drug is effective for preservation, and are we too late in restoration of vision? Coming to the conclusion and the end of my talk, optic pathway glioma occur in around 15 to 20% of children, mainly before the age of 8 years. Mostly they show an indolent course, but they may cause severe visual impairment in some of those children. So regular ophthalmology screening is necessary. And if there is visual progression, MRI response and vision differ once they get treatment. Other glioma, meaning glioma outside of the optic pathway, they in children are mostly low-grade glioma. High-grade glioma are rare in children. You might wait and see if those patients are asymptomatic, and if surgery is feasible, it should be done. Chemotherapy is effective in those children. Coming to future aspects, MEK inhibitors may be novel options for those kids, but we have to clarify whom to treat and when to treat. Thank you so much for your attention, and I would be happy to take your questions.
Thank you very much, Amedeo, for this very long and very, very thorough lecture, which leaves room for very little questions, actually. We have some questions coming in from the audience. A couple of them have been partially answered and regard the use of MEK inhibitors to treat PGs. And I wondered if you could comment a bit more on your and give your actual opinion on the use of these MEK inhibitors to treat low-grade gliomas in children.
Well, I think it has been shown in quite a few case series and the studies that I've mentioned that MEK inhibitors might be an appropriate second-line options for those patients. So far, the gold standard still is chemotherapy with carboplatin vincristine, albeit vinblastine. If you look at the Canadian group, And I think we have to await the results of the comparative trials looking at a comparison between chemotherapy and MEK inhibitors in first line, because we know that chemotherapy is safe and is effective, at least for the progression-free survival, considering the growth of the tumors. We have to see whether the functional outcome is better with MEK inhibitors than it is for chemotherapy, because then it might be a game changer. Then we might switch over. But I think so far we need to await those data before we can clearly say that this is the best first-line option. And once again, these are novel drugs. For chemotherapy, we know the the long-term toxicities, and there are almost none for those agents that I've listed now. Whereas for MEK inhibitors, we just don't know. We are treating patients with benign tumors that have an almost normal life expectancy. So they might see any problems occurring in 15 to 20 years' time that we might not even be aware of. So so far, and looking at mouse models, there should not be an issue for fertility, but we just don't know. So I think the gold standard still is chemotherapy, but you should consider, if those tumors are progressing, MEK inhibitors as soon as possible afterwards.
Thank you, Emilio. Very, very clear answer. There's a series of questions from Luigi Berlessina. The first one is whether there are any published references for the follow-up intervals after diagnosis in children of a PG.
Well, there are some guidelines. For example, Pete DeBlanc, and I think at 2017 review had some, and there will be the recommended intervals that will be published quite soon, Q1 2022, from the European Reference Network Genturis. I've mentioned those guidelines before, so yes, it should be at least half yearly. What we would suggest, and I've said that on one of the slides, to perform the visual acuity testing every 3 months in the first year after diagnosis. We would also perform MRI quite frequently in the first year after diagnosis, because once you get those tumors diagnosed, what you don't know is what has happened before. Were they already there and stable for a long time, or were they just developing and are now fast growing and might lead quite fast to visual deterioration? So it should be more often right after diagnosis, and then if you see, okay, there is a stable thing ongoing, that you might widen the intervals.
Thank you, and I will take up this reference from Peter Blanc, Luigi, and I will send it to you because I have your email from the chat. Another question from Luigi Berlessina: are gliomas involving the hypothalamus, should they be monitored endocrinologically?
Of course.
And a third one, does spontaneous regression of asymptomatic OPGs occur more commonly at a certain age?
Of symptomatic?
Of asymptomatic.
Yeah, well, they do occur. We've seen it. If you look at the publications from the Hamburg group from Victor Mautner and colleagues, they could show that actually if you do a cross-sectional analysis of children compared to adults, that the rate of optic pathway glioma in children is higher than the one in adults, meaning that what we would presume is that some of those tumors do regress. I've seen such patients. It's quite uncommon, but it does occur. But I wouldn't know about the exact numbers, and I don't think that anyone would. But looking at adults and children, it's not as frequent in adults than it is in children. So there must be something going on there.
A question from Ahmed Pandon. Is there a way to apply the discovery of Dr. Pan of Stanford University, which showed that the excitation of neurons in the optic pathway is necessary for the initiation of tumor formation, and that preventing this excitation actually prevents OPG in mice?
Yeah, well, you know what that means actually is that mice were, I've seen that study, mice were put in their black box. So there was no light exposure for those, and that those patients, those mice without light exposures had less tumors. So I'm not quite sure on how to bring that into humans. but maybe so. Maybe I didn't get the information right out of the paper, but this is what I understood from that paper.
There are lots of messages thanking you for the talk. A question from Carlos Lopez. Up to what age do we have to be aware of the appearance of these tumors?
As I've said, the highest risk is below the age of 8. Some even say below the age of 6, but we know that there might be rare cases of symptomatic optic pathway gliomas being caught later. The question is whether they're already present earlier and only get symptomatic later, or were they already symptomatic but were not diagnosed. So what our guidelines, the new European guidelines, will say is that you should do ophthalmology exams up to the age of 8 in any patient at diagnosis. If those patients get diagnosed with NF1, get diagnosed with NF1 after the age of 8, they should get an eye exam. And then, of course, above the age of 8, if they develop new visual symptoms or signs, then they should get an ophthalmology visit. So this is to make sure that you get them all. But it all mainly focuses on the young kids.
Great, thank you. Another question from Margarita Gomez. Are the symptomatic patients those who were diagnosed earlier? Or...
Not necessarily, no. So as I said, there are 2 risk groups looking at age. The ones below the age of 2 and the ones above the age of 5. So for having a bad visual outcome at the end. So apparently those that have very aggressive tumors that occur very early in life, when even ophthalmology screening is hard to do, they might be diagnosed so late that therapy might not be as effective. And for those that get diagnosed later on, I can't really tell you what the reason is. Maybe they did just were not screened earlier because they didn't get the diagnosis of NF1 earlier. I can't tell you exactly what that reason is. But yes, age does play a role, but we do not quite understand why. But this is very similar to sporadic cases, so that the very young ones are the bad players. But we might see also a visual deterioration in any age. So it's just not that if a patient is 4 years old, you can be sure that he won't have a visual impairment. So absolutely not. You have to look for that.
Then a question that sounds very difficult from Gianluca Piccolo. He says, in the case of a pediatric low-grade glioma that is refractory to both carbo and vincristine and vinblastine, would you try a MEK inhibitor, and which one?
Of course I would, and I would give the one that I get access to, because I think that there's a class effect, meaning that it does not really matter whether you use trametinib or selumetinib. So far, we've mainly used trametinib because it was so much easier to get. I have to make you aware that this is an off-label use. Okay, so these drugs are not licensed for optic pathway glioma in children. So if you do it, it's an off-label use, and you have to be aware of that. You have to inform the patient about it. But yes, I would. And looking at, for example, young children, you would not be able to give selumetinib because there is not an oral formulation or liquid form formulation for that drug. There is one of trametinib. And once again, you have to get this via the the pharmaceutical company because it is not marketed anyway. So, but most of the data and the studies that have shown is on selumetinib. Okay, so but this seems to be a class-wide effect.
Thank you. There are thanks again for the talk coming in. Then I have a question myself, which would be the last question, I think, unless some new ones come in from the audience. And the big question in OPG is when to treat. And I was wondering if you could tell us, you know, if there is a consensus, and you know, in the community as a whole as to when to treat. And what do you think should be done to try? I mean, can something be done to try to reach that consensus?
Well, yes. You might know that David Walker from Nottingham is working on that, and then he's trying to reach an agreement there. And he was one of the major players in that European cohort that we put together, and where I showed a few slides on that. Because this is what we wanted to reach, to see which are the patients at risk that we have to catch early and treat early in order to prevent them from losing vision. And this is what one of my last slides was actually showing, whether this preservation of vision versus the improvement of vision, if there is already bad vision, if there is already an impact. So it's quite hard, and we need to answer that question. Of course, what I would love to see, and I've asked that question actually on the NF symposium in Paris, and around 60% of respondents at that talk that I gave there said that they would wish to see, for example, a randomized trial on whether or not to treat for those patients where there is uncertainty. There is clear certainty that a patient with a pure optic nerve glioma with normal vision should not be treated. And there is clear consensus that a patient with dropping vision and bilateral tumors in the optic tracts should be treated. But there are quite a few number of patients, and unfortunately, this work done by David Walker was never published because it was rejected by a few journals, which is a pity, because he was clearly showing which groups of patients there were no consensus on. And for those, it might be interesting to have a randomized trial in treating those children to really see do those children or would those children profit from treatment. And if you have, for example, someone who is almost blind with pale optic discs, a bilateral involvement of the whole optic pathway, you will treat such a patient for sure, but you have to expect them to actually not profit from functionally considering vision. So because we fear that we are too late, and they even might drop in vision, although the tumors are responding radiographically. So this is a very important question. We are not there yet because we are always designing new trials for novel drugs to get those into play. Of course, the question always is, if you treat a child where you're uncertain whether he will actually need treatment, whether chemotherapy is really the only option you have, whether there would be some other drugs that have less side effects, that you would be more willing to give in a randomized setting to a child where you're not sure whether he will actually at some point need treatment. So I'm sorry for that long answer, Marco, because
no, it was a very good answer, I think. Thorough. We have one last question from Gianluca Piccolo. It's a very long question. I'm going to try to make it short. Because of the treatment, because of the difficulty in measuring the visual potential in children younger than 4 years old, the year-end guidelines actually suggest an MRI in children older than 2-year-old. is this an indirect way of suggesting that MRI screening should be performed on all asymptomatic patients?
You got me on that one because, our center has the experience to do MRI screening, and we see the profit of it. I know that some other centers don't because they don't see the profit of it. So it's very hard to answer that question. And this was a kind of European compromise on saying that we know that young age is a limiting factor, but we know that there are some ophthalmologists that are able to perform visual acuity testing even in very young children. It takes about half an hour or something for a child to do this preferential looking testing, for example, with teleacuity cards, and where they have high certainty. And I know that many centers don't do MRI screening, and they will not start doing it because they say they feel confident with what they're doing, and the guidelines actually cover both of these aspects. If you go by the American guidelines that are quite recent, I can't name the first author of it. Anyway, what they suggest is that performing an MRI on an asymptomatic child looking for optic pathway glioma is a decision to be made by the treating physician and the parents. And I think this is the best compromise there is. So clearly, what the guidelines say is if there is unreliable ophthalmology exam, or if the ophthalmology exam is suggestive for optic pathway glioma, you must perform an MRI. This is the clear answer. Okay. If there is unreliable eye exam, or if there is worsening, you have to repeat the eye exam shortly thereafter. This is what the guideline is saying. Okay. And if you can't perform it better, you have to do the MRI. So the answer is no, this should not be the back door. But on the other hand, it should not forbid those centers that have very good experience with MRI screening in doing that. Kind of a political answer there.
Just for you to know, Gianluca Piccolo further commented saying that they do MRI screening too, but only once the patient is collaborative, and therefore without anesthesia.
But this is not a high-risk population then? Because above the age of 6, when patients are really cooperative to do an MRI scan, at least Austrian patients with NF1 wouldn't be very collaborative below the age of 6. This is not, well, then it's not the high-risk population anymore.
Well, thank you so much, Medeo, for today's lecture. It has come to an end. We have we're 8 minutes past the time. Thank you to all the audience for being here and for their participation. Just a little update on the general info masterclasses, that the next 4 masterclasses are now ready to be registered for on the info masterclasses webpage, and the YouTube channel, which link you will find also on the info page, is active, and this masterclass should be posted on there just before Christmas in all 7 languages, if you wish to come back to it or to refer it to your colleagues. Thank you very much, everyone, and hope to see you soon.
Thank you so much.